Hello, my name is Dr. Sapna Kuchadkar. I am the director of the Johns Hopkins Pick You Up Rehabilitation Program, and it's my pleasure today to talk about rehab-related perspectives for the COVID-19 pandemic, a pediatric ICU approach. So anyone who has met me knows that I'm very passionate about the use of social media for dissemination of information about ICU rehab and pediatric critical care, and hopefully that's why you all are here. So please do engage on Twitter, follow me at @SapnaKMD, follow hashtag PedsICU and hashtag ICU Rehab. But in addition to that, obviously we're here also to talk about the pandemic and how it relates to ICU rehab. So please follow hashtag COVID-19 as well. For those of you who are interested in following along to all of this content on both social media and in the literature, we've created some very convenient links that will take you directly to all pediatric content related to COVID-19. So if you're interested in the Twitter content, and if you have colleagues who aren't on Twitter, for example, they can still take advantage of this content at bit.ly/PedsICUCovid. And then we actually have an automatic PubMed search that's updated periodically, actually updated every second, bit.ly/PICUCovid PubMed. So if you go to that link at any point in time, any paper related to pediatrics and COVID is available there. So I did want to start this talk by giving you a little perspective on my perspective. So I've had an interesting last several months. I actually had COVID-19 myself. I was one of the first 200 cases diagnosed in Maryland, which brings a unique perspective to the whole notion of caring for COVID patients. And I was actually deployed to the adult ICUs to care for these patients after I returned from my isolation period. And that period of time really gave me a fresh and also very important perspective on caring for COVID patients across the age spectrum. And here are just a couple of my own experiences with incredible PT, OT, SLP colleagues and all of the interprofessional staff that I was so fortunate to work with during that time. So we're here to do the pediatric ICU rehab related perspectives. However, there are 3 other webinars in this series for you to check out. First, there is the post-ICU recovery clinics by Dr. Ann Parker. That's been archived, as well as the adult ICU rehab webinar. And those are all available at the link that you see below. And the hospital-wide activity and mobility promotion in the pandemic is coming up September 30th from 11 a.m. to 12 p.m. USA Eastern Standard Time. So please do check that out, and the links to register are all available at that link below. So our objectives today are to talk about pediatric post-intensive care syndrome, because if anything has come out of COVID-19 and the pandemic, it's this heightened awareness of the importance of addressing post-intensive care syndrome, both in the adult and the pediatric populations. We're going to talk about COVID-19 issues and what's different for the pediatric patient in the ICU. How can we optimize outcomes for kids, and also share some available resources, including our upcoming virtual Hopkins conference. And finally, I think the most important part of this is a discussion, learning from the experience of all of you and our community. I'm very pleased to have 4 of our incredible Pick You Up champions on the call with us who will offer their perspectives and expertise from their interprofessional areas. So I'm pleased to welcome Hallie, Steph, Yun, and Beth to the call as well, and you'll meet them later on. So we're all here because we want to improve outcomes for critically ill children and also for their families. And there's no question that when children and families are admitted to the hospital, often the expectations are very different from the reality. Often families expect that their child is sick and they come to the hospital, they'll get better, and they'll go back to life as normal. But we all know that it can be a very tangled path with several steps forward and sometimes, unfortunately, even more steps back. So we can't just focus on survival anymore, because our survival rates are very, very high. We do a wonderful job of saving patients' lives. However, survivorship is a major focus, especially in the times of the pandemic. So our adult colleagues created the post-intensive care syndrome framework for new or worsening impairments in various areas, including mental health, cognitive impairments, and physical impairments that impact not only the survivor, but also the family. And fortunately, we now have a host of studies and literature specifically focused on pediatric post-intensive care syndrome. And these are just some of the most important references. If you read one paper on post-intensive care syndrome, I highly recommend reading this paper by Manning et al. In PCCM 2018 on post-intensive care syndrome pediatrics, which is a beautiful conceptual framework showing the wide breadth of the impact of PICS on children and their families. We recently wrote this commentary in the Lancet Child and Adolescent Health, and I'm going to read this because we not only put it in the context of the pandemic, but how really all of these issues are basically exactly the same, and that we just need to have a heightened awareness now that we have this ahead of us. Our growing understanding of PICS in pediatrics emphasizes the importance of developing interventions to mitigate the burdens facing critically ill children and their families. That outcomes from critical illness need to be explored in the context of a global pandemic, wherein wider determinants of child and family health might be impacted. We need preventative, multidisciplinary strategies for early rehab, minimal but effective sedation, delirium assessment and prevention, fostering a sleep-friendly environment, and family-centered cares, which has already impacted PICU practices and culture worldwide, but we need a lot more work. So let's talk a little bit about COVID-19 in kids. What do we know about the epidemiology? Well, we know that a minority of the confirmed cases of acute pediatric COVID-19 infection is in children. And we will specify acute versus what we are currently dealing with in a large segment of the population that are impacted by COVID-19 as kids. Critical illness from acute infection is rare, approximately 1%. And infants less than 1 year, not surprisingly, are most likely to be hospitalized. And there's a large number of children who may be asymptomatic, but the true proportion is still relatively unknown. This is a paper from earlier in the summer that showed the projections for the total number of infected and severe pediatric cases. And as you can see here, the numbers are increasing. And as we get better at testing and we have a wider swath of the population, we're starting to understand more and more about the scope of COVID-19 in kids. These are some of the most common symptoms for acute COVID-19 infection. And again, luckily, most children have very mild disease from acute infection. However, something new is on the horizon, and we're all learning more and more about it. And this is a paper that we recently wrote about the impact of social media on dissemination of information worldwide about COVID-19. Obviously, we don't all have time to wait for every single paper to get published to learn about this. We're learning from our colleagues, just as you all are here learning from all of us and me from all of you. So COVID-19 was an important hot topic for children. However, we weren't seeing a lot of critical illness, and then the WHO in March of 20 declared it a pandemic. But then what we saw in April, all of a sudden the interest in this area rose significantly. And why was that? Because the Pediatric Intensive Care Society announced that they were seeing a rising number of cases of this Kawasaki-like syndrome in children who either had a positive COVID-19 test or didn't have a positive test, which got everybody's attention. So this new syndrome is the multi-system inflammatory syndrome in children associated with SARS-CoV-2 infection. And this is a hot off the press systematic review from all papers published on MISC between January and July of 2020. So I encourage you to check that out. And it talks about all of the different symptoms that are seen. So clearly a complex syndrome, but one, luckily, if recognized early, these children do relatively well. But the important part is dealing not only with survival, but also the survivorship. This is also a hot off the press paper that came out in the last week by my colleagues Hari and Barnaby, who actually are leading the way in MISC research as well as ICU rehab research. And those of you in Europe and across the world probably know Dr. Schofield's work with regards to the PERMIT study in ICU rehab. This is not meant to be read on this slide, but I did want to draw attention to this figure because it's a very important delineation of the differences and the definitions of MISC. But the bottom line is we're all dealing with the same thing, which is sick kids who we need to address survivorship for secondary to the COVID-19 pandemic. So these are the typical symptoms of pediatric post-COVID-19 infection or MISC. You can see it impacts the mucocutaneous system. Systemic inflammation is a key issue, neurologic, cardiopulmonary, and gastrointestinal, which all play a significant role in how we rehab these patients. So the title of that paper that just came out was Time to Collaborate, and we absolutely agree. Time to collaborate. And there's never been a more important time to collaborate than now, but I would argue that this is something that we should have been doing for a long time, and hopefully we continue to grow in this area. And this is just a few people on my interprofessional Pick You Up champion team who make it possible to liberate critically ill children every day. So how can we optimize COVID-19 survivorship across the continuum? Whether you're a child or an adult, meticulous attention to our ICU evidence-based interventions. And in pediatrics, one of our biggest challenges is we don't have a ton of evidence-based interventions. Much of what we do is built on the adult literature. However, much of what the adults are doing make just as much sense, if not more sense, for the developing brain. So we need to combine physical and neuropsychologic rehabilitation, social support, especially for families. And this starts in the ICU and continues after they leave our units. So let's get to it. Why can't we just get to it and start changing practice? Well, first, we really need to understand what we were doing in the first place. So it's really important to understand what was our current practice with regards to early mobility and rehabilitation before COVID-19. Well, luckily, we do have that literature in pediatrics. So these are two, again, very recent papers focused on physical rehabilitation in critically ill kids, a multi-center point prevalence study that was done both in the United States and in Europe. We have studies coming from Brazil, Canada, and Australasia soon, but I would like to present briefly some of the findings from this study. What we did was we looked at every single child that was in the PICU for greater than 72 hours on the 2-point prevalence days in each of the studies, which meant that we captured approximately 60% of all the PICU patients in the units at any given time. So this infographic summarizes our Park PICU US findings. So essentially 35% of all the patients received PT or OT provided mobility on the study days, which actually was surprisingly higher than I expected, yet much room for improvement. How often were patients completely immobile? This is stark and important. 19% of those patient days that we collected, patients did not do anything. There was no activity associated with that patient. However, of the patients that did have activities, there were only 4% of 4,700 activity events that actually were associated with a potential safety event, and mostly always, that was always a transient vital signs change that didn't have a long-term effect. This was impressive and important. Who's at risk for a delayed PT-OT consult? Who do we wait a long time before we actually get in PTO and OT involved? It was the patients that had higher baseline function. If you were a straight A student or a star football player, you were less likely to have rehab introduced early because we probably have a bias that these kids are going to do okay. And we know from Karen Chung's work and many of my other colleagues that even the children with normal baseline function have significant impact and impairment after their ICU stay. In the US, females were less likely to receive PT or OT provided mobility. That requires extra exploration, and the youngest patients were less likely. And that's very important because 62% of all the kids in the PICU greater than 3 days are under the age of 2. So we are taking care of a very vulnerable young patient population at the highest rapid rate of neurocognitive development. Not surprisingly, factors that promote mobility were parents present at the bedside and having a mobility protocol. And barriers were endotracheal intubation, but also surprisingly having a urinary catheter, independent of everything else. If you had a urinary catheter, you're less likely to get out of bed. The findings were very similar in Europe, which shows that internationally, we have very similar work to do, which means we need to collaborate. Again, patients with higher baseline function, they did not find the gender-based difference, which is important, but they did find that the youngest patients were less likely. Families were critically important in getting patients out of bed and mobilized. So this is just a schematic that shows you the proportion of patients who had a PT or OT consult by PICU day 3. And you can see here those numbers increased significantly as the level of impairment increased. This is a slide I can't emphasize enough, both in the US and Europe. Nurses are central to PICU mobility. They are the cornerstone. They are at the bedside 24 hours a day. If you're a nurse listening to this, you know that you have a critical impact on the patient's ICU rehab potential. And it's our job to give nurses the tool across all interprofessional disciplines to help the nurses facilitate, and we need to be a part of that. So you can see here, those numbers were very similar. And then the barriers. Not surprising, medical contraindications, circulation, heart, being too sedated, isolation precautions. And isolation precautions are probably the new biggest barrier or challenge that we have to COVID-19 rehabilitation now. We are very fortunate, unlike our adult colleagues, that most children's hospitals still allow at least one parent to come to the bedside and be at the bedside despite COVID-19. And I'd love to hear more about how your hospitals are tackling that in the discussion and Q&A. So new barriers, similar solutions. If you take anything away from this webinar, it's that we need to go back to basics. COVID-19 and MISC, yes, it's a new disease, new syndrome, but the ways that we deal with the survivorship issues are essentially the same. So this is a very nice paper that applies to children as well about strategies to optimize ICU liberation, or the ABCDEF bundle, in the times of the COVID-19 pandemic. Just as a reminder, the ABCDF bundle is really just a common sense approach to putting together different aspects of ICU-based non-pharmacologic care to optimize patient outcomes. So what about kids? Bottom line is ABCDF is applicable to children, but we have some challenges: heterogeneous ages in development. We worry about tubes falling out. We worry about kids remembering their PICU stay. So all of those things aside, though, there are ways for us to apply the ABCDF bundle, COVID or not, to optimize pain and sedation, sleep promotion, delirium prevention, mechanical ventilation, so that we can get patients mobilized and optimize their functional outcomes. And you can see all of the potential outcomes that we could be improving as a result. I think many of you would agree that this is often the paradigm that many of us in the PICU practice under, that when we sedate patients, we sedate them for our own comfort levels so that we know that bad things won't happen. And we've created this vicious circle phenomenon where if a child isn't sleeping well, we give them more medicine, and then their sleep-wake cycles are impaired. If they're delirious and agitated, they're less likely to mobilize, they receive more drugs, and they're in the hospital longer because they're weaning off of all of these medications, and they're also not ready to leave the hospital because their physical function is impaired. So we can't deal with these things in silos. We have to deal with them together, which is why we're talking about this. Liberation needs to be a intercomponent, multi-component approach. So we need to continue delirium screening. We need to help others do it. There's many, many times where I'll ask a resident or a nurse practitioner, can I help you do the delirium screen? Let's pull out the pediatric delirium screening tool together and let's do it together. Looking at all possible reasons for delirium, and really everything that we're doing is very similar to pre-COVID. We need to be reducing sedation, reviewing deliriogenic medications, helping with day-night, opening the shades first thing in the morning, and addressing isolation. Luckily, kids have less of that issue because they can have a parent at the bedside often, but using Zoom, using other modalities to make sure that we are interacting with families and children to the best of our abilities. And then there's no question that we need to get our PT/OT colleagues to the bedside early and often. Again, these things shouldn't be our normal. Baths at 2 a.m., daily x-rays at 5 a.m., all of these things, COVID or not, we need to make sure that we optimize those, because essentially what we're doing is we're hitting the easy button. It's easy to give a bath at 2 a.m. because that's when things are quieter, there's less to do. Doing an x-ray at 5 a.m. so I can have an x-ray available to me to look at on rounds is not the reason to do the x-ray. We can optimize our routines to take the best care of our patients. So we need to collaborate. We need to bring our interprofessional colleagues together. And we need to use the same principles. They're just more important now. So every kid, every day, we need to get our experts to the bedside early. There's never a time that we should be sending a PT or OT away because a child is quote unquote too sick. We need to start with analgesia first. If you hear that a child is intubated but doesn't have an opioid or analgesic on board for the noxious stimuli of the ET tube, say something. It's not enough and it's not right to have just a patient on sedatives without analgesics. We need to start with analgesia first and then sedate if needed. Kids and families can tell us what they need. We need to incorporate them into our care plans. And sleep hygiene and delirium prevention means more mobility. If a patient is awake and alert and lucid, they can participate in rehab. So many of you know we have the Pick You Up program at Hopkins, which is a stratified program that we created. And we talk a lot about this at our virtual ICU rehab conference. Each level is associated with the activities, and we have criteria to pause and reassess. We have a shared mental model for the whole unit for every kid every day to talk about what is the most that a child can do from an activity perspective. And you can see here, a major emphasis is on sleep promotion. Activity progression continues, and it's really a tailored approach. Every kid has different needs, and we work with our rehab team, our nurses, our interprofessional colleagues to make it happen for every child. And I think the most important thing here is that rehab is safe, and studies after have shown time and time again, 0% adverse event rate over 737 PICU days in our own PICU Up study. And while we didn't have this huge increase in ET tube ambulation, we did start to actually get some patients out of bed. And the key thing here is to make sure everyone knows that early mobility is a spectrum. If you have a child on a ventilator at very high settings on CRRT and who can't be mobilized due to multiple activity restrictions from a surgery, we can still normalize their sleep-wake cycle. We can still optimize and make sure they don't have pressure ulcers, they don't get pressure ulcers, range of motion exercises. Our rehab team colleagues can be critically helpful for all of those things. And ambulation isn't the goal for everyone. I always finish by talking about the importance of therapeutic cuddles. We need to ask our families if they want to hold their baby today. Often we get so sucked into our daily routine of talking about critical illness and systems-based approach. A family member standing there, we engage them in rounds, but we don't ask them, do you want to hold your child? How can we make that happen? And I can tell you that almost every parent in the world will say, there's nothing more that I want than to hold my child, but often they're too scared to ask. So we can make that happen, work with our nurses, work with our physicians, nurse practitioner colleagues, RT colleagues, and you can see a couple examples. And this is a child who's very sick, but we can still make it happen safely. So the take home for Back to Basics is while COVID-19 is a novel disease, the approach is really consistent with our current best practices. Just keep doing the good work and make sure that we are consistent. We have to implement practices that are not a simple task, but we need to share our experiences. We need to talk amongst ourselves, which is why I'm so excited today to talk to all of you about what you're doing. How are you optimizing things so we can help each other with what we've learned along the way. And the team effort, it goes without saying, is the best part of ICU rehab work, is the most interprofessional work, I think, in the entire hospital. And it's an absolute joy to work and collaborate with these colleagues as opposed to working in our silos. So we want to make sure that you know that you have plenty of tools to take care of these COVID-19 patients. We want to share our resources. So with no further ado, just a few reminders about the resources that are available. First, we have a webinar series, as I mentioned. This is one of the webinars, but there are 3 others. The links are below, as I mentioned before. We have a Pick You Up page, so you can see the website here, easy to remember. We have an entire PICU rehab reference list with all of the studies up to date with regards to PICU rehab literature. We have an intro presentation, Pick You Up in Action, lots of stories and news about ICU rehab in the pediatric intensive care unit, and patient and family interviews. So every year we interview a patient and their family member about their rehab experience, and I think those are the most educational aspects of our conferences, and I encourage you to go watch some of our past interviews on the website. You can go to the activity and mobility promotion site, which is primarily adult-based, but again, many of these facets can be applied to our pediatric patients. And you can see here, we have numerous webinars available that have been done previously. The Outcomes After Critical Illness and Surgery page, it has tons of helpful resources and links to videos and reference lists. ICUdelirium.org, incredibly helpful resource if you're getting started with delirium screening or need to kind of step it up in the delirium screening realm. And they have an entire page dedicated to pediatric ICU delirium screening tools. The 2018 PADIS guidelines, as well as ICU liberation tools from the Society of Critical Care Medicine, are available here. Dr. Needham has the adult ICU rehab page, and you can see there's a host of resources available, including sedation, delirium, and sleep checklists, mobility and rehab guidelines, scales and scoring, and also finance and budgeting to optimize resources. And you can see the OASIS website here. A monthly ICU rehab email if you're interested in getting more involved and would like to get the monthly email that Dr. Needham sends out with tons of resources. You can email this address. And then we have a learning network, the mobilization network. You can follow us on Twitter and Instagram at PickYouUp, at SupnaKMD, and obviously use the hashtags ICU Rehab and Peds ICU. And here is a website describing a bit more about the ICU Recovery Network. It's a simple version of Facebook, essentially, and you can see that it's very easy to get started, and you can get started by emailing that same address as for the monthly email list. So we have many resources, as you can see, and I'd like to ask Dr. Dale Needham to tell us a little bit more about the 9th Annual Critical Care Rehabilitation Conference that is coming up very soon.
Hi, for those that don't know me, I'm Dale Needham. I'm the Activity Director of the 9th Annual Johns Hopkins Critical Care Rehabilitation Conference. We're going virtual this year, and I want to spend a few minutes and explain what that means. The conference is as great as ever, but will be delivered in a virtual format. There will be 100 presentations with 46 hours of content, more than 60 expert speakers. And there's 2 different ways that you can participate in the conference. Through registering for the conference, you have both options available for you. The conference materials are pre-recorded and made available starting mid-October all the way till the end of November. So there's on-demand viewing at your convenience from home or work, any time zone that you want. You can also participate in addition live on November 5, 6, and 7. As per the conference agenda and brochure, all of these lectures will be done according to the brochure with live question and answer sessions and with live workshops. And those question and answer sessions and workshops will be recorded and provided on the conference website for the latter part of November for those that couldn't experience them live. The conference also will have a virtual exhibitor hall, as I'll explain, and will continue the great tradition of having abstract winners give oral or poster presentations through the virtual format. The primary way that the conference is being conducted is through Zoom and Zoom webinar software. So in addition to this novel virtual format, we're going to continue many of our traditions. We're going to continue live tweeting. We're going to have fantastic interdisciplinary content. And the main conference on the second 2 days continues to focus on the latest updates. That's why so many people come back to the conference year after year after year, is the main conference is all brand new content each year with evidence-based content from the latest publications. And as I said, if you can't watch it live, the content is available on demand for you to view from mid-October to the end of November. Importantly, with the virtual conference and the recordings, we're so fortunate to be able to have English subtitles added to all of the recorded presentations. This will allow people, for example, who have English as a second language or hearing impairment to be able to experience the conference in a better way than ever before. And as usual, we will, at the end of the conference, provide a cumulative reference list that's going to be many, many pages long of all of the content that's presented, all of the evidence from the conference. We still have the same fantastic speakers and planning committee members, some of whom are shown here. These are all the planning committee members for the adult and the pediatric portion, as well as many other fantastic speakers. The virtual exhibitor hall is one of the highlights of an ICU rehabilitation conference because it really focuses on the specific products and services that may help you with delivering ICU rehabilitation. So we are very fortunate that many professional associations and organizations have continued to join us through a virtual exhibitor hall that's offered through the web. And in addition to viewing the products there, you can, if you wish, leave your name and contact information, and the exhibitor could get back to you and provide more information or answer your question if you wish. There are many approaches to online registration. that I want to try to summarize here. Some people may only be interested in our brand new pre-conference on ICU follow-up clinics. We do offer that separately. As I said before, it's available from mid-October to the end of November's on demand, or you can watch it live on November 5th. That's almost 8 hours of content. Some people may only want the basics. I'm not quite sure why they wouldn't want all the latest updates, but some people may only want the basics. We try to have everything, different options for different people. And here you can pick 2 of the 3 foundation courses on adult or pediatric ICU rehab, or hospital-wide activity and mobility promotion, the Combating the Hospital Immobility Harm conference or course. You can pick 2 out of those 3 and register and get those. But what we most recommend is either the main conference or the all conference content. The main conference will give you the latest updates, as I said, from 2019 and 2020, and also allow you to select one pre-conference foundation course, one of the 3 courses that's listed there: adult ICU rehab, pediatric ICU rehab, or combating the hospital immobility harm. So you get to select one of those along with either the adult or the pediatric main track. And then for people who want absolutely everything, we do have the 46-hour all conference content option that gives you the pre-conference, the 3 foundation courses, and the pediatric and adult main conference. You can register at the information at the bottom. And if you've got any questions about these options, you can email us at icurehab@jhmi.edu. So with that, we're going to now move forward and have the interactive discussion and question and answer in order to hear the problems that everyone's facing and collectively get wisdom from the registrants for this webinar for solutions that you're finding helpful in your own ICU rehab practices.
Thank you so much, Dr. Needham. And thank you to all of you again for listening to us talk at you for the last half hour. But really the best part of these webinars is always the most interactive part of it, which is our discussion and Q&A. And we're here to provide insights from our interprofessional team. And I'm joined by these wonderful people on the screen right now, but also to learn from all of you across the world. And it's really exciting to see such a wide range of folks across the globe joining us. So I'd like to quickly go over kind of the instructions for the Q&A and discussion. First, if you'd like to submit a question in the Q&A section, go ahead and do that. In the Zoom, you just put in the Q&A, and if you actually like one of the questions, that'll actually push it up farther in the queue, so please feel free to do that. When you're prompted, if you have something that you'd like to ask live and not put it necessarily in the Q&A, or you have a comment on a question that we're actively answering or talking about, please do raise your hand, and I will do my best to make sure that we call on you. And I hope to have a very interactive conversation with everyone. So with no further ado, I'd like to introduce my interprofessional champions, colleagues from Pick You Up, and I'm just going to go based on the order they are on my screen. So we have Steph Morgenstern, who is our nurse champion, Beth Wazorek, who's our nurse practitioner champion, Hallie Lenker, our PT champion, and I think I see Yun, or she should be joining us. There's Yun Kim, who is our OT champion. So with no further ado, we are going to go ahead and get started. We already have a couple questions in the Q&A, which I am going to go ahead and get us to start to answer live. So the first question was from Paul Ricard about the OT-PT point prevalence in the Park PICU study. Commented that it was 35% and that I said that that was low. What was your expectation of prevalence? So I was actually surprised that it was 35%. I was expecting it to be lower, so I was pleased to see that. Not being a rehab team member, my assumption was that it would be closer to the 50% number, but I'd like to call on both Hallie and Yun to comment on their thoughts, given obviously the rehab team isn't seeing every single kid every single day in the PICU, but what would your expectation have been? We'll start with Hallie.
Yeah, so I think for us, it was 35% seemed a bit low. I agree with Sapna that we would have anticipated a little bit closer to 50%, although I think taking into account the type of ICUs that we're kind of looking into, thinking the idea that it would be that PT or OT were providing some type of service rather than an actual mobility event. We anticipated that would be a little bit of a higher number, probably closer to that 50%, not over that probably.
Yeah, and anything to add?
Yeah, I agree. I definitely think it will be about 50%. But that was just looking at a 2-day time period. I think for OT, when we see our level ones, we don't see them as frequently. We kind of do more of a positioning, education, splinting, and kind of more play that consultative role than that daily intervention.
Great, thank you. The next question, I believe, is from Zaf. Thank you. So the question is about the most challenging aspect of analgesia and sedation management among the bedside nurse, parents, junior trainees when you decide to start early mobility in post-op surgical patients, and how did you overcome these challenges? So I'll start with my perspectives and open it up to my panel. From a physician provider perspective, I think the main challenge was that we always want to start very heavy with the sedation and analgesia. So often, especially with our trainees, they would start with a fentanyl or a morphine infusion and a dexmedetomidine infusion and stay away from benzos, even if we have gotten rid of the benzodiazepine culture. And we didn't get into that so much here, but we talk about that a lot at the conference. The doses would be really high. So what we really had to encourage our team to do is this whole start low, go slow strategy. So if a child is naive to opioids and only receive them in the intraoperative period, they might not need a fentanyl at 1 microgram per kilogram per hour. It might be completely sufficient to do 0.3 or 0.4 and increase from there. And another key component, and I can ask Steph to speak to this in a moment, is making sure that we're all speaking the same language with regards to sedation. So using the state behavioral score is critically important. And Steph can tell you that the nurses they're documenting the SBS routinely all the time and every few hours. But the medical team wasn't speaking that language. They weren't saying my SBS goal is blank. So if the SBS is 1 and we want it to be a 0, we want to give this medicine. Steph, do you want to comment on kind of the challenges from a nursing perspective?
Yeah, absolutely. I think to that point, the speaking the same language is really important. We've done a lot of work just with JCO compliance and how we order our medications, and so that we are all speaking the same language. What's the indication? At what SBS would you use this? So that these decisions become a little bit more systematic and collaborative. So, if you've gotten to this point and you've given your phase 1 sedative or analgesic and you don't feel like you're well controlled, you then have a conversation with the team. You talk about what is your goal and how do you achieve it, both in the context of SBS, but also functionally. If your goal is to be up and ambulating, but also have good pain control, how do you get there if you're not there now? So I think the biggest thing is just speaking the same language and having the communication be really open and collaborative so that it is clear what the ultimate goal of the day is. So we talk about that every day on rounds. What is the goal? Not just pick you up 1, 2, and 3, but functionally within those categories, what does that look like for this patient?
Thank you, Steph. Beth, I'd love to hear your thoughts from the nurse practitioner and resident perspective, since you're the ones that are called to the bedside first when there's these sedation challenges.
So I agree with Steph. I think our compliance was born out of JCO, but it has helped that we now have to be more specific about why we're ordering the sedation and exactly what our expectations are for the child, and try to work away from the expectation that the child has to be completely still and more towards the child is allowed to move as long as they're moving safely.
Thanks, Beth. So the next question is from Megan Kupferschmidt, who also is a huge rehab champion and has created their own rehab program in their unit. I think, Steph, this is the perfect question for you. How do you overcome the fear of bedside staff of losing tubes and lines and getting infants up to parents' arms?
Yeah, it's a great question. One thing that I think ultimately helps down the line is once you've seen it done safely, you feel convinced. So part of it is just, you got to start somewhere. And once you've shown people that you can do it without significant safety events, then it becomes something that people can really believe. to get it in the forefront, I think it really just starts, again, with really open communication, with use of all of your available resources. This is not something that you do alone in a room and throw the baby into the patient, into the parent's arms, right? We do a lot of prep. We talk to the parents about what we expect them to do, right? Which is mostly let us kind of handle it. Sit here. Which way would you like your kid's head to sit? Let's get you fully ready. Let's have appropriate pillows and support for you so that you'll be comfortable once the child is in your hands. Let's talk about what all of these tubes are and how important they are. And so once the child is in your hands, you know, respect them and ask questions. Don't pull on these. And if you feel like you're tangled or you need to reposition, ask for help. We're here, and that's what we want to do. And then the next thing is to get the appropriate healthcare personnel in the room. So we routinely use in respiratory therapy therapists to maintain the tube. We will often have 2 to 3 nurses there guiding tubes and drains as we move, and then somebody who's actually moving the child. So we will almost always be moving, especially a baby, the child ourselves, and then placing them in the parents' arms rather than asking the parents to lift them and go and walk and sit with them in their hands. And, you know, we all know that navigating lines and tubes can be very difficult and almost hard to entirely anticipate, which is why we often have a nurse in the room that's really just looking for things that might get tangled as you move, and move slowly, because you can always stop. If something starts to pull, you pause. The room is quiet. We're just having open communication as we move through it. The other thing on the forefront is anticipating worst case scenarios. So what vital sign do we expect is going to change with this? What would be a threshold for us to abort? And then, you know, what would be an acceptable change in vital signs that we could potentially ride through? Can you safely rescue the child while they're in their parents' arms? Do you still have access to suction and an ambu bag and all of those things? So those are things that we look at before we ever start moving. Where the patient is positioned, can you still see them? Can you still access all that emergency equipment? So some planning on the forefront, some good communication as you move through it, and then use of all of the available resources that you can.
Great, thank you. That was a very comprehensive answer. Anyone on the panel have anything to add to that?
I think the one point that Steph really brought up of making sure the nurses are there with any mobility technique, I think is really how you increase comfort. I think often nurses are very busy, and I completely understand, and they can think of when PTOT, speech are there, I can get some documentation done. But if it's a new mobility activity or a newer nurse, I think really trying to coordinate our services as the therapist as well around times that will work for the nurse.
Great, thank you. Next question is from David Pascal Rojas Flores. Asked, is there information in Spanish? I'm interested in helping translate it. Many people still do not understand English, as in low and middle income countries, especially, and bringing them closer to them will be great. I think that's a spectacular question and comment, David. So we did start slowly, and I know many of my colleagues are definitely interested in exactly what you commented. So I'd love for you to reach out to me. My email address it's very easy. It's sapna@jhmi.edu. If you're interested in translating any materials, we're always open to collaboration. In a second, will, when I'm typing, I'm trying to put things in the chat link for you all. So I will put the Spanish infographic that was created for the Park PICU study, the link to that in the chat box, so that you have access to that. And then, yes, there's definitely a lot of room for us to continue to collaborate and make this more globally available and representative. Thank you. So there's a question from Nora that is, what type of specific interventions that OT can provide? I think this is a great question, because I don't think it's broadly something that everyone is aware of.
Yeah, and that's one of the topics that we're going to be presenting during our rehab conference. But I think there's 2 phases and 2 age groups. The first phase is when they're at that level 1, they're pretty sedated. We really focus on positioning and splinting, really to promote more of a muscular skeletal alignment and prevent any skin breakdown. We also do a lot of education with nurses and parents, and it also depends on the age group. So if they're more of an infant and toddler, we focus more on the developmental stim. While if they're older kids, we might more provide age-appropriate stimulation that might not be overwhelming while they're in the ICU. And then later on, when they're more mobile and more awake, our focus it varies from communication. I mean, ultimately the OT goal is to help them with their daily activities, and that is engagement in play, helping with self-care. With infants, it'll be more of oral motor to prepare them for feeding. So there's definitely a lot of things that OTs do in the ICU. Unfortunately, there isn't that much literature to support it.
Thank you, Yen. I did want to call on, is it Sharam? I'm sorry, I'm not sure which question you had a comment with regards to, but we can unmute you so you can make your comment or question. Sharam, if you can unmute yourself. All right, we will come back so that in the interest of time, so we can keep going with the questions, which there are many. So the next question is also from Paul. When looking at the frequency of therapy or mobility sessions, do you look at intention to treat / mobilize to help determine room for improvement, identify barriers, etc.? So Hallie, would you like to start with that one?
I think it's a really good question. And Sapna would have to tell me for sure from the park data if it was attempts were taken into account or not.
So there, we actually did not look specifically at attempts. That's something that would have been interesting to look at. Yeah.
Correct, and I agree, and I think that would be something that would be an interesting thing to look at. I completely agree, and like kind of seeing where we think we know what the barriers are, and I obviously are supported with the information that we've had, but I think finding that in more concrete ways across the continuum would be very interesting, but it was not taken into this data.
Yeah, and just to follow up on that, I mean, the ultimate goal of our Pick You Up program, and I think any mobility program that any of you develop and implement in your units, is that if we don't get our rehab team to the bedside and start that interprofessional communication and education, there's really not going to be major culture change in any unit. And we learned these are the intangible things that are really hard to quantitatively collect and describe in the data. So for example, one of the side huge benefits of Pick You Up is that as our rehab team came to the bedside, didn't get turned away, and the nurses got to know the rehab team, and I'm sure Steph would agree, as the nurses and the rehab team create their own relationships, a lot of times, a lot of this mobility was happening outside the purview of the medical team. And really, I mean, that's the goal. The medical team would comment if there's some specific restriction, but honestly, it's the people who are at the bedside touching and caring for the patients that are driving this, and giving them that, that empowerment to do so, I think has made the biggest difference. Okay, so next, actually, it looks like Sharam is unmuted. So did you want to go ahead with your comments?
Sorry.
No worries.
May I ask my question, please?
Please, go ahead.
Thank you for your webinar very much. I saw in your slides that an intubated child was accompanied with his mom. Is it really necessary for that? I think it will increase the risk of infection, COVID-19 for his mother or her mother. Is it really true?
So Sharam, are you speaking specifically to patients who are known COVID-19 infected, or patients regardless of their COVID-19 status?
I saw a child infected with COVID-19 that accompanied with his mother in his bedside, intubated child. He was unconscious. Is it really necessary for child to be with his mother?
I think in situations where the patient is COVID-19 positive, and since we do allow, even in our COVID-19 rule outs, and Steph, correct me if I'm wrong, but in COVID-19 rule outs or known infections, we do allow a parent to be at the bedside, and it's assumed that these parents have had significant interaction with their child and have already been exposed. So in those scenarios, obviously there's always the increased risk of aerosolization, but if the parent is already in the room, they've chosen to take on that risk, obviously, and as a parent, it's hard not to. So we don't find that there's any additional risk from, for example, holding the child if the parent brought the child into the emergency room or PICU, presumably themselves. So we do try to limit, obviously, inter-touching contact, whatever's needed to optimize the functional outcomes of the patients. But we do not restrict our rehab team colleagues, don't have specific restrictions to coming and seeing those patients, because now with adequate PPE, I mean, that's the biggest, that's the biggest factor. You have to have adequate PPE. If you have adequate PPE, there's no reason to restrict those interactions. Anything to add, Steph?
No, I agree. And I think, one of the things that we think about is that our intubated patients are actually in a closed circuit system. So they are not actively aerosolizing. So the risk is not dramatically different. They're actually probably higher risk if they're on non-invasive ventilation or high flow nasal cannula, something like that, that is truly aerosolizing. But agreed with Sapna that the parent who's in the room is presumably already exposed, and we limit their coming and going. They're really only allowed one parent that stays in the room for the entirety of their stay, and so they aren't necessarily getting exposed to their patient and then coming out into the common spaces. They're staying within that room and reducing exposure to other people.
Thank you, Steph. So in the interest of time, we have lots of great questions, so I want to keep moving. So Kelly Smith asks, what additional barriers to early mobilization have you encountered since the beginning of the COVID-19 pandemic? So I would actually like to ask our champions here to answer that question, because they've all been taking care of these patients in varying capacities. So let's start with our rehab team colleagues. Hallie and Yun, what barriers have you encountered since trying to optimize rehab for these kids?
So I think in the beginning, just kind of the day-to-day changes and what we could and couldn't do. I'd say that was our biggest thing, especially when in our area when COVID was really, our numbers were going up. Now that things have kind of settled out and we have our new normal, I'd say some of our kind of barriers are a little bit more just around for our aerosolizing patients that are on high flow. We can't mobilize them outside the room, which we were able to do previously. And we also have a bit more PPE needs for those kids, regardless of their COVID status, which same idea, just kind of changes how sometimes easily you can see those patients. But otherwise, I actually don't, at least from a PT standpoint, we haven't had too many changes. It's just being a bit more mindful of things.
Yun?
So for OT, I think for the aerosolizing rooms, like some of the limiting certain equipments or toys that we might have typically just easily brought up and left in the room. The other thing, even like utilizing the playroom, I've kind of forgot like how often I used the playroom, even for the kids in the PICU, just even using the playroom as a motivation to get them up and moving around. But because of the whole COVID, we're not, all the playrooms are closed currently. And for the infants, the fact that we have to wear a face mask and face shield, and that facial expression kind of gets lost. And that's been a big barrier of like that social interaction, social smile, especially some of the toddlers who's really scared already being in a new environment, and then we're wearing all this mask. I think it's just harder for them to like get them more comfortable, more soothing to participate in therapy.
Beth, I'd love to hear your perspective from the medical team rounding and trying to optimize these things.
Oh, there was a period where our rounds were limited to Zoom rounds. So that was a little bit more challenging to have interactions with the nurses and with the families. We are now doing walk rounds again. And so we have been able to increase our interactions, and it just makes planning a little bit easier when you are face to face.
Great. And then Steph, what from your nursing perspective?
Yeah, I think one thing is just kind of considering isolation practices and what limitations those pose. And so we are using airborne isolation for obviously any patients under investigation, anyone who's COVID positive, but also even if they've tested negative and they are receiving aerosolizing procedures. So all of those patients are limited to their room. We do absolutely still ambulate them inside their room, but that does pose kind of a new limitation in there. It limits some of the motivation for the kids sometimes. But we have been pretty active with all of the other patients who are not on aerosolizing procedures and not on airborne isolation, and still getting them up and walking in the hallway. We like to incentivize some of things like walking past the playroom, which as Jan talked about, we can't go into anymore or currently, but also to getting to the end of the hallway where they can see out the window and see different sights and sounds and things like that. So that is really helpful, and we continue to use that where we can. And then we are collaboratively coming up with kind of creative ways to motivate them within the room if they are not able to move outside of there.
Thank you. So we have 2 more questions currently. So this is a great one for Hallie and Yun. Are you seeing a trend for brachial plexus injuries in the pediatric population?
No more than typical. I haven't seen an uptick.
Yeah, I'm assuming this is for related to prone positioning, if it's related. No, we haven't really had any brachial plexus. And before the COVID, we used to prone infants or children who are in pretty ARDS. The OTs, we also make custom positioning to kind of put them more in alignment when they're in prone. So I don't know, but I never really had to deal with the brachial plexus injury.
Okay. And if anyone on the call wants to comment, if they've observed any, please feel free to raise your hand. And then we'll move on to Kalpana Singh's question. Thank you for your nice comment. And for smaller PICUs with average 3 days ICU stay and less frequently intubated patients, how can these rehab practices be inculcated in daily patient care and studied to motivate other colleagues in hospital admin? Beautifully phrased question, and perfect question, like that kind of encompasses the entire mission that we have and why we do webinars like this. So it goes back to kind of that whole, the spectrum that I showed of mobility. And whenever we talk about early mobilization, I think everyone's first knee-jerk reaction is that, like, we want to start walking all the intubated patients all over the unit. Like, and I want to emphasize, and all of you should go back to your own units and emphasize that that is absolutely not the ultimate goal. Great, it would be awesome if we walk a couple intubated patients, but I'll be honest, I can't remember the last intubated patient that we did walk, because often when patients are intubated, they are so critically ill that they are not in a position to walk. It's very rare to have a patient who is intubated and stable in all other regards to go to ambulate unless they're very long-term intubated patients. So the key here is actually to start with the lowest hanging fruit, which is the unintubated patients, the patients who are on nasal cannula or high flow or even on room air. Sometimes I think we become so ingrained in our practice of, okay, let's just go through systems. And then when we talk about the musculoskeletal system, for some reason, today's activity goal isn't even mentioned. And it's important that as the medical team, we state an activity goal for every kid every day. So if that goal is get out of bed to chair 3 times today. Now, our rehab team colleagues might have a modification to that. They might say that they can do more or less, but at least as a medical team, we're thinking about it, talking about it. And then the other piece that I would say for hospital admin and to motivate is to, again, have your rehab team present in the unit. Like, so our rehab team wears maroon scrubs. So it's awesome because we see maroon scrubs everywhere now because that's just our culture and routine. And before that wasn't always the case. So I think to motivate, you start with the lowest hanging fruit, celebrate those small successes. Many of you have heard me say that when we just bought a lot of cake and pizza at the beginning. Whenever we like mobilized a kid that we normally wouldn't have mobilized, we celebrated. We shared photos with the staff if the family provided us with permission. It just kind of keeps people thinking forward, and we're always pushing the envelope, and the envelope for us is very different than it was 4 to 5 years ago, for example. And then I think we have time for one more question from Lorena. Can you talk a little bit more about the positioning interventions you provide for patients in prone and any pictures that you can share? And we can think about posting some pictures soon. And I know Yun definitely shows many at the rehab conference. Yun, you want to?
It's my talk this year.
Oh, okay, great. So either of you want to comment on that?
Yep. So it is. We have a whole kind of mobility equipment positioning talk around this year, especially around pictures. and exactly what we fabricate, especially for our younger kiddos. I can, I don't have anything that I can share offhand right now. If you're going to be at the conference, that'd be fantastic. And then you can look at it there. But there are some, especially for older patients, like in your more adolescent and above, there are quite a few articles that are out there that I can see if I can find. And if I can find them and tweet them to Sapna, and she can share them with everybody in the world.
Absolutely. And I will also add them to our Pick You Up Rehab reference list. And I did want to note, it's bit.ly/PICU_up, all lowercase. So I wanted to click, sometimes it's case sensitive. So use it in all lowercase, and we'll add it to the reference list once Hallie sends it to me.
Yep, I can send it tomorrow.
But that's a great, great question. So I think we actually got to every question that I see in the Q&A, unless someone else tells me otherwise. And unfortunately, we are all out of time. It is exactly 12 o'clock Eastern Standard Time. So I just want to thank you all for joining us. It's been wonderful to interact with you and just be able to share our perspectives. And we'd love to hear more from you. Please do register for the conference and join us for some more interactive Q&A. There will be tons of it. And finally, thank you to my spectacular panelist colleagues for sharing their insights as well. Thank you all.
Thank you, everyone.